Picture your body for a second as this incredibly brilliantly engineered skyscraper. You've got the intricate lattice of steel, the suspension cables, those massive foundational blocks. And for decades it stands tall. It weathers storms, bears just immense dynamic weight, and somehow moves with incredible grace. But what happens when the core of that skyscraper, the very foundation keeping it upright, starts sending out relentless distress signals? Well, welcome to this explainer. Today, we're going to act as diagnostic detectives. We're cracking the case on one of the most common, yet honestly deeply misunderstood mechanical failures of the human body: back pain.
All right, let's dive right in. We are talking about the human spine, literally your body's central support column. Every single time you lift a heavy box, twist around to grab your keys, or heck, even just sit upright at your desk, this highly complex structure of bone, nerve, and cartilage is hard at work. But when it suddenly fails under immense pressure, man, it brings everything else to a grinding halt. We're jumping straight into the science today because here's the thing. Back pain isn't just some random, meaningless ache. It is a highly specific, localized alarm system. And to figure out how to stop that alarm, we first have to decipher exactly what the alarm is trying to tell us. And to do that, we need to realize back pain is not a single disease. It's a symptom. It's just the scene of the crime. So let's look at Section 1, the lineup, 4 prime suspects. All right, suspect number 1 is degenerative. Think of this as structural fatigue in our skyscraper. The clinical data describes this specifically as a dull, aching pain. This isn't usually an overnight disaster. It's the result of slow, gradual wear and tear on the spine's mechanical structures over time. It's that heavy, persistent ache as a support column that has just been carrying way too much load for way too long. The cushioning discs between the vertebrae slowly dehydrate, the joints kind of grain together, and those surrounding ligaments, they actually thicken in response over years and years. Then we have suspect number 2, inflammatory. Now, what's really fascinating here is the distinct shift in the pain profile. We move from a dull ache to a sharp, shooting pain. This happens when the body's own systemic or localized inflammatory response basically turns aggressive. It essentially attacks the spinal framework itself. It's sudden, it's piercing, and it behaves totally differently from simple mechanical wear and tear, often showing up with really intense stiffness right after periods of rest.
Let's move on to suspect number 3, which is nerve root compression. The absolute key characteristic to watch for here is a burning sensation. Remember, your spine isn't just structural, right? It is literally the main electrical conduit for your entire lower body. So when a structural anomaly, like a bulging disc, puts pressure on those sensitive nerves exiting the spinal column, it's exactly like faulty, pinched electrical wiring. It sends these hot, burning, radiating signals right down the line.
And finally, we have suspect number 4. This one is a total master of disguise: renal colic. The clinical documentation points out that this pain arrives in these agonizing waves. But here's the crazy twist. This isn't actually a structural back problem at all. It is a systemic plumbing disaster. Think kidney stones or biliary stones, basically masquerading as back pain. See, because the nerves carrying distress signals from your internal organs actually share pathways with your back, the brain gets confused. The internal distress is so severe that the pain refers outwards to the back, just rolling in these relentless rhythmic waves. So the crucial takeaway here is that our first major diagnostic clues come directly from analyzing the specific profile and feeling of the pain itself. We have to interrogate the symptom. Which brings us to Section 2, interrogating the symptoms, identifying the pain profile. Let's break down this comparison. On one hand, we have the baseline mechanical structural ache of degenerative issues. It's dull, it's heavy, it's persistent. Now, contrast that directly with the aggressive, sharp, and shooting pain of an inflammatory cause. Just by identifying the texture of the pain, we've already eliminated half of our suspects. The mechanical ache is basically a slow burn, whereas the inflammatory response feels like an active, aggressive attack. And this brilliantly illustrates the next major divide in our investigation. If the pain feels like an electric, localized burning sensation, well, we are almost certainly looking at a trapped nerve root. But if it feels like rolling, agonizing waves that crest and fall, building up to a massive peak, subsiding slightly and then returning, we have to look completely away from the spine's structure. We need to check the body's internal plumbing for stones. But of course, the investigation doesn't just stop at the initial site of the pain. We gotta follow the trail. This brings us to Section 3. Following the trail. Where does the pain go? Because in spinal diagnostics, the radiation pattern is just as important as where it starts. These radiation clues are absolutely vital for narrowing down just how bad the problem is. For example, if the back pain radiates to both legs,
bilateral leg involvement, this is a massive red flag. The data points highly toward chorda compression or cauda equina syndrome. Now, these are severe neurological emergencies where the entire bundle of spinal nerves is literally being choked off. On the other hand, if the pain radiates down just one thigh and leg, we're usually looking at the classic pathway for sciatica. The geography of the pain maps perfectly to the specific nerve being compromised. And this brings us to our core clinical cheat sheet. Clinicians actually map these distinct characteristics and radiation pathways using a really precise framework: onset, progression, duration, characteristics, and radiation to isolate the true cause of the structural failure. By systematically charting these exact elements, doctors can literally draw a map from the outward symptom all the way back to the hidden origin point. It's just a brilliant logical flow of deduction.
Okay, now for the final piece of the diagnostic puzzle. Once we know what the pain feels like and where it goes, we move to section 4, the modifiers, triggers, and relief. Basically, we need to know exactly what mechanical actions trigger the pain and what actually brings relief. Consider how specific actions completely betray the underlying cause. Take an intervertebral disc prolapse or cord compression. The pain increases with everyday increases in internal pressure. We're talking about movement, straining, coughing, or even just sneezing. Seriously, a simple sneeze can trigger pure agony because it forcefully spikes the pressure inside your abdominal and spinal cavity, which pushes that compromised disc even further into the nerve. Conversely, look at stenosis. With stenosis, the pain steadily increases with walking, but decreases dramatically with rest.
And right here is where we find a truly fascinating mechanical reality regarding spinal stenosis. The clinical data shows that sitting, or specifically bending forward, actually decreases the pain. Now, why is that? It's because the physical act of leaning forward, spinal flexion, physically opens up the spinal canal just a fraction of a millimeter, and that is enough to relieve the pressure on those compressed nerves. Think of it kind of like loosening a tight belt after a really large meal. If leaning forward brings immense relief, well, spinal stenosis becomes our absolute prime suspect.
But as good diagnostic detectives, we must also be heavily on guard for what we call sinister clues. We look for progression, pain that doesn't just stay the same or get better with rest, but continually and aggressively worsens over time. Furthermore, if the pain is not relieved by lying forward, resting, or changing positions, well, the framework tells us we need to shift our suspicion completely away from simple mechanics. These relentless red flags actually point toward far more serious, non-mechanical invaders, things like potential malignancy, ankylosing spondylitis, or a severe bone and joint infection. By combining all of these elements, we reach section 5, solving the diagnostic mystery. You now have the structured framework to understand exactly how clinicians narrow down the suspects. You combine the texture of the pain, its geographic radiation trail down the legs, and those mechanical modifiers that either trigger or relieve it. Suddenly, back pain is transformed from this confusing, monolithic nightmare into a highly solvable diagnostic mystery. So the next time you, or maybe someone you know, feels a twinge, a heavy ache, or a burning sensation in their spine, remember this investigative framework. It is not just a bad back. It's a specific, localized signal. The evidence is all there, just waiting to be interpreted. So the only question is, are you listening to the specific signals your central support column is sending you?